And Professor, would you prefer if I run it as a didactic lecture, or would you ask me for the residents to participate and take the cases?
Of course, yeah. So please, if you, my request for you guys, please take an active participation and ask your questions. Don't be afraid. You can ask any question you have.
Yes, that would be lovely. It will make it more interactive for sure. Thank you, Professor. Okay, well, thank you again for the invitation. I'm really, really excited to speak with all of you. Today's topic is going to be imaging evaluation of the sellar masses. My name is Atul Agarwal, and let's get started. So anytime I start a lecture, I always start it with the anatomy because that is so important in radiology. And specifically in this lecture, we're going to learn about the sellar and suprasellar anatomy. We'll discuss in detail what structures occupy that space, and that is going to help us down the line to see how the anatomic findings align with the patient presentation to really discuss more in detail any benign or malignant pathology that involves that space using a categorical system. So my hope is at the end of the hour, you will be very, very familiar with the anatomy of the sellar space. You'll be able to interpret the findings of the masses that you see in this space. And then knowing the patient presentation, putting it all together, you'll be able to generate a diagnosis and a differential diagnosis. So if that sounds like a worthy cause, let's proceed. As I said, we'll start with the anatomy, and you'll see that there is considerable overlap in the sellar space. There can be lesions that are sitting inside the gland, inside the pituitary, so those are intrasellar lesions, or they may be sitting on top of the gland along the infundibular tract. And there may be mixed lesions that go up and down and involve all these different spaces. So you'll get a sense for how much overlap is in this small space in the brain. So to lay the land of the bony anatomy, because that's going to become important as we talk about some of the pathological lesions, we have to understand that the sella turcica, or the hypophyseal fossa, is actually a depression in the basisphenoid, the sphenoid bone. And then you see two edges to the bone. One anteriorly is called the tuberculum sella, and posteriorly is called the dorsum sella. And the pituitary gland sits right in the middle in the hypophyseal fossa. You also see that there is an exit for the optic nerve in the optic canal, and that's going to become important as we see masses that can expand and compress upon the optic chiasm, inciting some optic neuropathy. Okay, and are you able to see my screen and hear me okay?
Yes.
Okay, perfect. All right. On the top, I am showing radiographic anatomy, just a normal anatomy, what you'd expect to see on any brain MRI. And the coronal T1 post nicely shows you the optic chiasm right at the top, and then the infundibulum coming down to the pituitary gland itself, the adenohypophysis in this case, which is bordered by the cavernous sinus, and you can see the enhancement in the cavernous sinus venous channels, except for the intracavernous internal carotid artery. And below that, you have the aerated sphenoid sinus with the sphenoid sinus septum. If you look on the images on the bottom, the left image is the one without contrast, the right image is with contrast. And I intentionally placed this pre-contrast T1 image in this lecture because the dorsum of the bone, the dorsal sella, can actually be very big in some patients. So that is not the lesion, that is the bone with the marrow that is bright, the T1 bright marrow in the bone. And you can see on the T1 fat sat post-contrast that marrow has suppressed and lost signal. So the pituitary actually sits in front of that dorsum sella. You can see the adenohypophysis. The P is the posterior pituitary bright spot, which is bright because of the lipophilic proteins, and then the infundibulum going up to the chiasmatic and the infundibular recesses of the third ventricle, and that same aerated sphenoid sinus in front of the adenohypophysis. Once we give contrast, the entire pituitary gland enhances, and you lose that posterior pituitary bright spot because there is avid enhancement of the adenohypophysis. There's avid enhancement of the infundibular stalk. And just mentioning again what I mentioned before, there is fat saturation of the bone marrow T1 signal in the bony sella. Any questions at this moment on the anatomy? Okay, this is more of a diagrammatic explanation of what we just talked about. So again, you have the optic chiasm, the infundibulum stalk coming down to the pituitary gland. There are several important structures that border the gland itself, and you can see this network of veins, the cavernous sinus, that invest the gland both superiorly and also inferiorly along the floor. So it's important to know that, because sometimes we see enhancement below the gland and we wonder what that is, and that is just the normal cavernous sinus enhancement communicating from left to right. What you also see are these nerve roots that are invested by this dural layer. So there's a medial dural reflection, and then there's a lateral dural reflection to the cavernous sinus. And that becomes important when we talk about cavernous sinus invasion in a few slides. So important to note, the third and fourth cranial nerves, V1, V2, actually are along the lateral border of the cavernous sinus, and the sixth cranial nerve, abducens, is in the substance of the cavernous sinus, very close to the cavernous ICA. And I'm showing this to you on purpose so you understand why, when there's invasion of the cavernous sinus by a mass, you can have cranial neuropathies. So very important concept to understand. The adenohypophysis, as I've shown, is the larger of the two glands, and it secretes the trophic hormones TSH, ACTH, LH, and FSH. The smaller portion of the gland is the neurohypophysis, which stores vasopressin and oxytocin. And this is just a diagrammatic explanation of all the different hormonal changes that result from all those hormones. Please note that the adenohypophysis has the portal system, and that is how the hormones are delivered to the anterior pituitary. In contrast, the posterior gland has nerve tracts, and those lipophilic proteins have to bring those hormones down to the dorsal gland, the posterior gland. Size is very important for us as radiologists when we're looking at scans, and we use Elster's rule, the 6, 8, 10, 12. It's a quick way to remember the different upper limits of measurement of the gland itself. So in neonates and children before puberty, it should be no more than 6 millimeters. In adult men and postmenopausal women, it can be as big as 8 millimeters. Women of childbearing age, because of the hormonal changes, the gland increases in size and becomes 10 millimeters. And when the person's pregnant or postpartum, it can be as big as 12 millimeters. So it's important to keep these size criteria in mind, because just because the gland is big doesn't mean it has a mass. It just could be because of hormonal changes from pituitary hyperplasia. So very important concept to keep in mind. Okay, another pause to see if there are any questions. I encourage questions. If you're unclear on something, we can take some time to answer those. All right, no worries. So let's actually dig into the substance of the lecture, starting with intracellular lesions. This is the first case I'm going to show. And if anybody wants to unmute, turn on their video, and just take the case and describe quickly the findings that they see on the slide. And I promise you I'll help you along. Okay, maybe the crowd will warm up as we continue the lecture, but let me show you what I'm trying to show on this case. The sagittal T1 pre-contrast shows you that the pituitary gland is enlarged, right? It's almost touching the optic chiasm. You can see that on the left image. I have a chat message. Okay. On the right image, you can see we have given contrast, the infundibular stalk is enhancing, and now we can really appreciate how large the gland is. So the differential diagnosis is of a enlarged gland. Looks mass-like, but it doesn't have any very heterogeneous features. So at this point, we can start thinking of masses, but it's also important to keep in mind the last slide I shared with you as far as the hormonal changes. So here's just a coronal T1, and you can see this dome-like elevation of the superior part of the gland. So this is nothing other than pituitary hyperplasia. As I mentioned before, this can be physiologic during the menstruating years and postpartum and lactation period. Uncommonly, it can also occur as a result of hypothyroidism because it causes an increase in TRH in the hypothalamus. And remember, all those hormonal changes come down to the pituitary and increase the production. So the gland is basically working overtime because of hypothyroidism. Even more rarely, intracranial hypotension can cause venous congestion and cause enlargement of the gland. And I'll show you an example of that case right now. This is a companion case. You see that the gland is enlarged, but there's something hypointense under the gland before it sees the bony fossa. And you can see that on the post-contrast sequences, you can see the avid enhancement under the gland and, in fact, going down the clivus. And on the right side of the screen, you can really appreciate the thick pachymeningeal enhancement all along the convexity. And this happened to be because of intracranial hypotension, and the offending lesion was, in fact, in the chest, in the hemithorax. We came across a cystic appearing lesion, and you can see on the right side of the screen as I scroll, there is a meningocele that extends into the hemithorax through the neuroforamina. So that's the third space phenomena causing the intracranial hypotension secondary to a lateral meningocele. Just a beautiful case of intracranial hypotension causing physiologic enlargement of the pituitary gland. Okay, that was the first case. The second case is before you, so anybody who wants to take a case, don't feel shy, and if I hear a pause, I'll just continue. Okay. On the left side is a sagittal T1 post-contrast sequence, and you can again see enhancement of the gland. However, there's a portion of the gland right in the middle that is not enhancing. And I've shown you the coronal sequences through the portion of the gland. You can see in the front there's enhancement, in the middle there is no enhancement, and finally there's enhancement on the posterior pituitary bright spot all the way in the back. So we have before us a lesion that is not enhancing in the middle. This is a companion case, so this is a different case, showing you on the pre-contrast there's a lesion along the infundibular stalk, so not in the gland, but above the gland. And then as I prefaced before, there's a lot of overlap of these lesions in the intra and suprasellar space. That same lesion is T2 hypointense on the coronal sequence. You can see how it's right under the optic chiasm. When we give contrast, we see that the infundibulum enhances and the lesion doesn't enhance, but there is a claw-like enhancement around the lesion. And you can appreciate that on the coronal T1 post-contrast sequence as well. This is yet another companion case, so a different case. And in this case, the lesion itself is very bright. It's bright on T1. Once we give contrast, the contrast is brighter than the T1 hyperintensity, and you can see that here, that same claw-like enhancement around the lesion, again appreciated on the coronal post-contrast sequence. So This is nothing but a Rathke's cleft cyst. When you have a lesion that's not enhancing but enhances peripherally, you're dealing with a Rathke's cleft cyst. These are often non-calcified. As I said before, they can be inside or above the gland itself. And it's very important to recognize that claw-like enhancement around the lesion, giving you the clue that this is a Rathke's cleft cyst. And there's a healthy differential to consider when you see a cystic lesion in the sellar suprasellar space. These lesions usually occur about age of 45. They're found incidentally. And most commonly, they're found because of the pituitary dysfunction they cause, because sometimes they get very, very big. And what I'm showing you on the right side is a arachnoid cyst, not a Rathke's cleft cyst, but an arachnoid cyst. You can see CSF intensity enlargement of the sellar suprasellar space. This thing is so big that it's compressing the third ventricle. You can't even see the optic chiasm, and the pituitary is flattened in the bony fossa. So this large thing was a arachnoid cyst. We likened it to a upside down snowman. So if you see something enlarged in the sellar space, think of cystic lesions. Again, a healthy differential, but if you recognize the claw-like enhancement, you can come to the conclusion that it's a Rathke's cleft cyst. All right. Third case. And you'll see how thematically we will build case after case, going through the different entities that we find in the sellar suprasellar space. So on the leftmost image, you may be hard-pressed to see if there's any lesion at all. Here's the gland. It looks pretty homogeneous, but the astute in the audience may realize, well, the left gland is slightly bigger than the right gland. And you're right. When we give contrast, you see that there's a lesion in the right gland that was not seen before. The T2 can be helpful sometimes, and these lesions can show up as T2 hypointense, but are very, very hard to see until you give contrast. So there's a unique technique that we employ, and you may do the same in your protocols when you do MRI of the sella, which is to do dynamic post-contrast imaging through the pituitary at 30-second intervals. So if you follow the images 1 through 6, as we give contrast, and this is a different patient, so the lesion's on the other side, you see that there's a lesion that appears within the pituitary, with the enhancement on the pituitary much more evident on the right side. I'm sorry, on the left side. And as you progress at 30-second intervals, the lesion becomes even more clear and more conspicuous. And what happens towards the end of those 30-second intervals is the lesion itself starts to fill in with contrast. So the hallmark of this lesion is slower enhancement than the remaining pituitary, right? So the gland will enhance quicker than the lesion itself. But as you wait, the lesion starts to fill in with enhancement. And that is why we can't rely on delayed post-contrast imaging to find these lesions, because by that time, the lesion itself has enhanced completely and fills in with the rest of the pituitary. So we have to take advantage of the serial 30-second interval of enhancement to catch these lesions in the early phase. So this is nothing but a microadenoma, and you can see a nice example of that in this image. This is an intrapituitary lesion, usually ISO on T1 and T2. That's why it's very hard to see, and it enhances less rapidly, and that's the hallmark. And most of these are found incidentally at autopsy because they're small and non-secreting. And we'll use this case to sort of segue into the next case, and it'll make sense in a moment. Professor, are we doing okay on time? And you can still hear me okay?
Yeah, it's fine.
Okay, thank you. The next case shows you a slightly larger mass, and you can appreciate how there's some remodeling of the bony sella. you can see how the sella, which used to be a very shallow, bony sella turcica, has now been remodeled and enlarged. And there's a large mass in that space. Very iso-intense on T1, very heterogeneous enhancement on T1 post, and you can see the same information in the coronal planes. This is a companion case or a different mass. Again, you appreciate the same remodeling of the bony sella, somewhat more homogeneous on T1 and T2. As soon as we give contrast, it's very heterogeneous enhancement, and you can see again the same information in the coronal plane. So this is the larger cousin or brother or sister of the microadenoma that we just talked about. This is a macroadenoma. And this is the most common cause of sellar masses in adults. And it's classified according to the size and functional activity. So most of these are going to be functional. The large
Excuse me, Professor. Yeah, your microphone.
Okay, can you hear me okay now? Okay, perfect. And because they're functional, they're going to be detected sooner because of hormonal changes. And so the patient gets imaging, they see a mass, it's smaller, they can take it out, or they can give the patient medication. And most common of these functional secreting tumors is going to be the prolactin secreting microadenoma. Now, on the other hand, if the lesion is non-functioning and it's not detected early because of hormonal changes, it comes to attention late. And because of that, it has had a chance to grow and get larger. And when it gets larger, it starts compressing other structures, as we saw in the brief anatomy lesson. And what I'm sharing on the right side is a coronal image of a macroadenoma that was largely resected. The portion the surgeon couldn't resect is in the right cavernous sinus surrounding the ICA. So that is a residual disease after resection of these large macroadenomas. Okay. As I alluded to earlier, macroadenomas get us in trouble because of compression. So as they approach the superior aspect, they compress the optic chiasm. Patient gets visual defects. They can also compress the third ventricle or the foramen of Monro, leading to hydrocephalus. And as they spread outward, laterally towards invading the cavernous sinus, they can cause cranial nerve palsies because of the reason we discussed earlier in the anatomy lesson. So the important hallmark of these tumors is they cause sellar enlargement and erosion. So if you see that on imaging, that's your first clue. There's heterogeneous signal primarily because they can undergo necrosis and hemorrhage. They're usually iso-intense on T1, as you said, but the enhancement is more inhomogeneous. Here's a differential diagnosis case. Again, a very large sort of mass, very similar looking, eroding and enlarging the bony sella, except it's bright on T1 to begin with. And you can see the difference is not very much once we give contrast, but as usual, the infundibulum enhances post-contrast. So what is this lesion? Very different. It looks kind of like a macroadenoma, but it's very intense on T1 before we give contrast. So this was pituitary apoplexy, and the hemorrhage is what's causing the T1 hyperintensity. So just a very nice differential diagnosis example of something that looks like a macroadenoma, but is something very different, in this case, pituitary hemorrhage apoplexy. Okay, any questions from anyone on the intracellular category before we move on to the suprasellar space? I'll give this a slightly longer pause just in case if anybody wants to unmute and ask a question. Okay, if not, we'll keep going, and we're going to segue to the infundibular, the suprasellar lesions next. Okay, and I start with this case because it's important and you may not see it in clinical practice. It's very academic, but I wanted you to at least know this, especially as you see pediatric patients and you're rotating in neuroradiology on the pediatric service, you may see this case more commonly. And just to explain how I've labeled the images, A goes along with B, C goes along with D, E goes along with F. And what I'm trying to show on A and B is the normal presentation of the pituitary bright spot. So here's the posterior pituitary bright spot. It's bright on T1 because of the lipophilic proteins. And you can see that in its normal location, both on the sagittal and the coronal images. In the middle column, you see that the bony sella is somewhat more shallow. The infundibular stalk is a little more truncated, and the posterior pituitary broad spot is actually higher than it usually is along the tuber cinereum. And you can see that on the coronal as well. And in E and F, I'm showing that the stalk is even more truncated, and the posterior pituitary bright spot is actually located at the infundibular recess of the third ventricle. So very, very high up. And then the coronal image shows the same information. So, this could appear odd, but all it is posterior pituitary ectopia. The posterior pituitary bright spot is there, it's just in the wrong location. And often you'll see absence or a very tiny pituitary stalk. And the pituitary, the ectopic pituitary will be along the median eminence of the tuber cinereum or the truncated stalk, as I mentioned before. You may also notice the bony changes in the sella itself, which may be small. And it's important to keep this in mind because this phenomena is associated with Chiari-1 malformation in a small portion of the patients because of migrational anomalies. So look for those as well if you see this case. Okay. Case 6, I have two images, axial T1 on the left, T2 on the right. And you can see on the axial, it may be difficult to know where this lesion is. But since this is a Sellar and Suprasellar space talk, you can imagine this is sitting somewhere in the sella or the suprasellar space, and you appreciate a iso-intense mass. And it's relatively iso-intense both on T1 and T2. And you can see that here on the coronal and sagittal. You see the same mass here above the pituitary gland, and here's the same mass here along the tuber cinereum. And the mass really appears clearly once we give contrast. You can see how homogeneously enhancing it is. There's some higher vascular enhancement inside of it. And again, you see the mass here. And as I scroll, you can see the mass distinct from the pituitary gland. In fact, the gland has a nice broad dural base along the tuberculum sella and the planum sphenoidale. You can appreciate that here. You can really appreciate the broad base along the planum sphenoidale on the coronal image. You can even see dural tails and more egregious vascular enhancement internally. Here's a companion case. So this is a different case of the same thing. T1 pre and post. Again, somewhat more difficult to see what's brain and what's mass. But once you see the enhancement, you can see this large pedunculated mass, very dural based with dural tail. In fact, you can see and appreciate the growth along the tentorial reflection with the dural tail. So I'm using buzzwords that will already signify to you what I'm thinking as far as a diagnosis. Here's another companion case of a different mass, same lesion. Again, much better seen once we give contrast. Here it is, along the tuber cinereum. I'm sorry, the tuberculum sella and the planum sphenoidale. You can see the dural tails. Again, somewhat distinct from the gland itself. Again, the broad dural base along the planum sphenoidale. So this is a meningioma. And these comprise about a quarter of paracellular masses. There's a slight predilection to the female gender, and these increase as you age. The important concept for us as radiologists is to appreciate that CSF cleft between the mass and the gland itself. And you'll notice that the sella turcica, the bone, is only mildly enlarged, unlike we saw in the macroadenoma, where there was really erosion and enlargement of that bony sella. So that's the clue when you're trying to decide between macroadenomas and meningiomas. As I mentioned earlier, these are usually iso-intense on T1 and T2, and that is why they're so difficult to see until and unless you give contrast. They can calcify, and that'll change the signal intensity on other series. Homogeneous enhancement is usually the hallmark, and the dural tails help differentiate this from a macroadenoma. If you have a CT scan of the same patient in the jacket, I really hope you look at it, because one of the things that meningiomas do is cause hyperostosis of the bone that they are planted on. And you can really appreciate that much better on a CT scan, where you see this blistering and expansion of the bone itself. And that's your additional clue that you're dealing with a meningioma and not a macroadenoma. When we talk about macroadenomas and meningiomas, it's important to talk about sinus invasion. And why is sinus invasion a bad thing? Well, it's bad because we talked about the cranial nerves that sit in the cavernous sinus earlier. So as and when the tumor invades, it can cause cranial neuropathies. And Dr. Nasp came up with this criteria. It's widely used. In fact, there are other criteria that have come about after this. So it's important to know that medial reflection can just be pushed by the mass. That doesn't mean that the mass has invaded the cavernous sinus. So it can become very challenging to know when the medial reflection of the dura is just being pushed versus when the mass is actually invaded. And what we often use as a good clue of invasion is when the mass is either in 2, 4, or 3, when it's actually gone beyond the cavernous ICA, that is beyond just the mass pushing the cavernous sinus, that it has to have invaded the sinus when it's sitting lateral to the cavernous ICA. And I'll show you a nice example of that here. Here's our pituitary gland, here's the mass, and you can see that this portion of the gland, all of this is sitting lateral to that cavernous ICA. So this is frank NASP grade 4 invasion of the left cavernous sinus. Just a beautiful example of the cavernous sinus invasion. An additional clue that you're dealing with a meningioma is that as the tumor invades, it actually attenuates the caliber of the ICA. It makes it smaller. Macroadenomas don't do that. Meningiomas do that because they're more cellular tumors. So when you see that narrowing of the ICA, you can be more confident that you're dealing with a meningioma. Okay. And I've shared with you where these arise from. Any bony landmark or any dural reflection really is a place where meningiomas can grow from. Okay, case 7. So this is a different case, and I've got 2 images before you. Sagittal, both sagittal, one pre-T1, one we've given contrast. And you can see there's something very wrong in the suprasellar space here already on T1. In fact, it's pushing on the pons here. But it's not until you give contrast that you really get to see this lesion. And this was sort of a cute lesion. It almost looked like a little mouse inside the brain. You can see its kind of ears here and the nose and the eyes. But you can see how the lesion has some solid enhancement, but it also has some peripherally enhancing cystic areas. And that's a very important clue to this lesion. Let's look at it in other planes. So here are some coronal images, T2, T1, and post-contrast. And what you'll notice, this is what I really want you to concentrate on. Sometimes when we see lack of T2 bright signal, we think it's solid. And sometimes we're right. For example, here, this portion is not T2 bright and it enhances, so it's solid. But it's also important to know that there can be areas that are T2 dark and not solid, as you can see here, this peripheral enhancement of this cystic area. So this is indeed a cystic area, it's just not bright on T2 because it has more proteinaceous contents in that space. So it's really the T1 post-contrast sequence that makes the difference as to what's solid and what's more cystic. This mass tends to calcify, and you can see a nice example on CT scan of a calcified lesion. This is a companion case, so it's a different lesion. Here's the lesion on T2 flare, and once we give contrast, there's some heterogeneous enhancement you can see in the sagittal plane. My stop sign tells me that's the last example of this case, and this is a краниофарингиoma. They arise from squamous epithelial cell remnants of the Rathke's pouch. It's important to know that these happen in two different age groups. The vast majority peak at the earlier, sort of a decade, and the smaller peak happens in the 5th through 7th decades of life. A lot of these lesions are going to be suprasellar, but it's important to know, just like we talked about earlier with the overlap, that some of these lesions can be both suprasellar, intrasellar, and some can be just purely intrasellar. So just because you see this in the gland itself doesn't mean that it cannot be a краниофарингиoma. They come in two different types. On the left is the adenomatous type, and that happens in the children. It's more lobulated, more cystic, can calcify, and the cystic areas will look differently on MRI based on what's sitting in the cyst. If it's more proteinaceous, it'll be less T2 bright. The solid portions always enhance moderately. The adult type is called the squamous papillary type. Remember, this is the 5th through the 7th decade when they present. These are more solid and spherical as opposed to lobulated that we saw in the children. And these are less likely to calcify. And they're even more rare to recur if they're excised by the surgeon. So these are just some of the changes and the differences in the two types of краниофарингиоmas that you'll see in the two different age groups. Okay, here's a differential case. It looks very much like a краниофарингиoma because it's solid and cystic, very heterogeneous on T1. Here's is the same mass on T2. And the surprising finding was the really bright susceptibility or the dark susceptibility signal on the SWI sequence, which really caught us by surprise. So we were thinking this is a краниофарингиoma, but it happened to be an intraventricular cavernous malformation. So just be careful. Sometimes you have masses that'll look like a краниофарингиoma, but instead they may be something very different. So you have to collect all the different cues on the imaging to come to the right diagnosis. Okay, this is our next case, case 8, showing some abnormal signal in the hypothalamus. You can see the T2 flare hyperintensity and expansion. Here it is on the pre and post contrast. And I'm showing the optic chiasm right here under the gland, and that gives you a little more confidence that you're dealing with something hypothalamic and not chiasmatic. So mass-like abnormal signal along with enhancement, that's one case. This is a companion case of a different patient. You can see that the pituitary, the chiasm, the optic chiasm is enlarged, and it does not enhance when we give contrast. So enlarged chiasm, non-enhancing. Here's the same patient, enlarged chiasm, non-enhancing. This is a second companion case, so a different case of the same thing. Here you can see a very large expansile mass, both on T2 and T2 flare. When we give contrast, you can see the mass-like enhancement extend into the prechiasmatic optic nerve. Yet a third companion case showing you a more heterogeneous mass in the optic chiasm and its continuation in the prechiasmatic optic nerve with trapping of the CSF in the optic nerve sheath. And here it's shown to be heterogeneously enhancing. So now I've shown you 4 different masses in the same space. And these are hypothalamic and chiasmatic gliomas. And it's very difficult to know if it's chiasmatic or hypothalamic when they become this big. So oftentimes we'll report them as combined hypothalamic or chiasmatic gliomas. This is a disease of young age, so usually in the first decade of life. And many of these will present with patients who have neurofibromatosis type 1. So it's important to know that association when you're diagnosing this disease. Excuse me. And as you might suspect, the symptoms that the patient is going to present with is going to be visual loss. And as these masses get bigger and bigger and they start compressing other things, you'll see hydrocephalus and hypothalamic dysfunction. It's important to note that half of these may not enhance. And just because it doesn't enhance doesn't mean it cannot be a glioma. So even when you see something enlarged and not enhancing, it could still be a hypothalamic or chiasmatic glioma. Okay, our next case is case 9. Again, showing you a lesion sort of in the sellar-suprasellar space. Here you can see it's really expanding that interpeduncular cistern here, T2 and T2 flare. And when we give contrast, it enhances avidly, really robust enhancement, very homogeneous enhancement. You can see the mass on the sagittal post-contrast sequence. Again, somewhat separate from the pituitary gland itself. It almost kind of looks like the intraventricular cavernous malformation that I showed you earlier, but that didn't enhance, obviously. So we have a really large suprasellar enhancing mass. And I haven't shared with you any details of the patient's age, which becomes very important in this case. This is a germinoma. And this is a very small portion of intracranial tumors. So small portion of these arise from the pineal gland or the posterior third ventricle. A larger portion will be seen in this location that we're discussing in the suprasellar cistern or sella. And be mindful that the germinomas don't have to be these large masses that you see. They can just present as thickening of the infundibular stalk. So we'll talk about this in a few slides, but if you see a thickened infundibulum in the right age group, you should definitely suspect a germinoma. Okay, these are tumors of young children. As I said, most common age is the first decade. Suprasellar germinomas, equal distribution. When you see it in the pineal region, the males have a slightly higher predilection. The most common symptom is going to be diabetes insipidus, visual field deficits, and pituitary dysfunction. And as you saw in this case, there's marked enhancement, and the posterior pituitary bright spot may be absent. And I get a lot of questions as to why that may be, and it's purely because of the compression of those of the nerve roots coming down, the lipophilic proteins. Because of the compression, you can't bring those transport proteins down to the posterior pituitary bright spot, and therefore you don't see it. Important to make this diagnosis early because it's very, very responsive to radiotherapy. Okay. Our next case is this one, showing you post-contrast images. And there's a wasting where the diaphragm of the sella would be expected to be. So the pituitary is enhancing, but then you have a waist, and then you have a suprasellar area of enhancement. You can see the same waist where the diaphragm would be expected to be in the sagittal image. And this is metastatic disease. Occurs to the pituitary infundibulum, as we're seeing in this case, right here, or it can happen to the hypothalamus, as we are seeing in this case. Mostly breast and bronchogenic carcinomas are to blame for metastases in these areas. So when you see metastasis, you think of looking elsewhere for breast or bronchogenic as a primary cause of this patient's metastasis. Not only that, but they can also come from seeding, CSF seeding of other primary tumors that are known to seed through the CSF, like ependymomas, medulloblastomas, germinomas, and pineoblastomas. So if you have these diagnoses, look to the pituitary to see if there's seeding and depositing on the infundibular stalk. Other malignancies that are very common to involve the CSF space include leukemia and lymphoma. So here on this brain MRI post-contrast, you can see parenchymal metastatic deposits, and that was our deposit in the infundibular stalk. These can present as small enhancing pituitary lesions without sellar enhancement. So if you just take away this large area, you can just see the sellar enlargement, the pituitary enhancement without the sellar enlargement. However, most commonly, you'll see this dumbbell morphology with the waist in the middle because of the invasion of the diaphragm sella. The metastatic tumor invades the pituitary, but then it grows through and invades the diaphragm to create this suprasellar mass. So if you see this, especially think of metastatic disease as the etiology. Okay, any questions at this point? We've sort of covered the anatomy, the intracellular lesions, and the suprasellar lesions.
Yes, we have some questions in the chat.
Okay.
Yeah, just let me read it. How can we differentiate a homogeneous schwannoma from a meningioma without performing perfusion imaging?
Can you repeat the question one more time?
How can we differentiate a homogeneous schwannoma from meningioma without performing perfusion imaging?
Yeah, from a meningioma. So schwannomas will cause remodeling, particularly of neuroforamina or skull-based foramina. But meningiomas will have the infamous dural tails. So when you see dural tails and you see the broad dural base of the lesion, that is your clue that you're dealing with a meningioma. Schwannomas will inevitably never show you dural tails. They'll never have a broad base along the dura. So that's the distinction, even before you do perfusion imaging.
So dural tails, they are specific only to meningioma, right?
That is correct. That is correct. You can see peel enhancement and dural tails when we think about sarcoid in the spinal cord, but that's going to be dural tails along the pia, not the dura of the thecal sac. So when we're speaking specifically of pachymeningeal enhancement, dural tails, you're dealing with meningiomas. So if you see it along the falx, if you see it along the convexity, if you're seeing it along the pachymeninges, yes, that's meningiomas.
What about the situations in cavernous sinus?
The
Yeah,
cavernous.
I guess this, it's related to the same question.
Yeah.
Right? Amina Talakbekovna.
The cranial nerve schwannomas can be very difficult, but you'll notice the different in epicenter of the lesion, right? If it's a cranial nerve schwannoma, it'll be centered in the cavernous sinus and the sella will look almost normal. You'll see a nice normal pituitary gland, and that is your clue that you're dealing with a schwannoma of the cranial nerve and not a meningioma that's invading the cavernous sinus. So the cavernous sinus, the pituitary meningiomas, the sellar meningiomas, you'll see a dominant mass in the sellar space and secondary invasion of the cavernous sinus, instead of the epicenter of the lesion being in the cavernous sinus itself. Majority of the cranial nerve schwannomas in that location are going to be in the cisternal space. So you'll see them in the prepontine cistern or the Meckel's cave. You'll very rarely see them in the cavernous sinus itself.
Thank you, Professor. Amina Talakbekovna, are you satisfied? And we have another question. Does DVI help in differential diagnosis between meningioma and pituitary microadenoma?
Pituitary micro. Okay. And you said DTI?
DVI. Diffusion related images.
Okay. DWI. Okay. Yeah. And you mentioned between meningioma and microadenoma?
Yeah.
Okay. Yeah. Not very much in my experience because both can be hypercellular and give you some degree of diffusion restriction. And that is why we rely on the other clues that we talked about, just because diffusion can be similar in both of those lesions because they both happen to be hypercellular. And one may be more heterogeneous than the other, giving you more diffusion restriction. So that is unfortunately not something that helps us differentiate in the clinical setting.
Yeah, and I also have the question from my side about diffusion, about perfusion. How do you think personally these advanced methods, they're not so useful for this localization, right?
That is correct. And it's partly because of where this lesion is. You're very, very close to the skull base. You're very close to the aerated sphenoid sinus. And as you know, there's so much susceptibility and inhomogeneity in the magnetic field because of the air and the sinus that you really, really struggle to get any useful information from perfusion. In fact, for the same reasons, the diffusion may be not very reliable just because you have so much artifact from the aerated sinus.
Thank you.
Of course, of course. All right. We'll move on to the final category, which is the infundibular stalk lesion. I already sort of alluded to a lesion that we can think about when we see in that space. This is a example that I put intentionally into the lecture because you may not see it very commonly in clinical practice. It's very academic, and that's why I put it in here so you're aware of it. And what I'm trying to show on the left image is this enlargement of the tuber cinerarium in the mammillary body. This is on pre-contrast T1. On the coronal T1 post, you can see that there are paired pituitary glands on either side. Here's the optic chiasm for reference. In the same patient, when we do an MR angiogram MIP image, you see that the patient has paired basilar arteries. And I'll show these to you on slice by slice so you can see it better. But this was a very peculiar case, and very occasionally this comes on your PAC station to read. And here are some more images. So there's the basilar artery becoming a paired structure, giving each individual basilar artery giving rise to its own posterior cerebral artery. You can see that here, the pairing of the basilar artery. And this is nothing but a duplicated pituitary stalk. So just something very unique you may never come across in the clinical setting, but I just wanted you to be aware of it. So these patients will have two stalks with paired pituitary glands on the coronal view. You can see that here. And these patients will also have tubomammillary fusion with thickening of the tuber cinerarium. And that's best seen on the sagittal view that I was showing you earlier. You can see that thickening and fusion best on the sagittal image. And finally, if you are lucky enough to have a MRA in the jacket to read, you'll notice the paired basilar arteries as well. So when you have this constellation of findings, think of a duplicated pituitary stalk. Okay, let's go to something more common that you'll see in clinical setting. One single image, sagittal T1 post, showing you, it may be difficult to see this lesion just because it's so iso intense to the rest of the brain. But as you hover in the sellar suprasellar space, you see the pituitary gland here. You see the infundibular stalk. This is where you would expect the tuber cinerarium or the posterior wall of the hypothalamus be. And you see that there is a lesion a mass-like lesion of the same signal as the brain, as the gray matter, in fact. And this lesion looked exactly like gray matter on every single sequence. In fact, it did not even enhance on the post-contrast sequence. So in the board setting, if you're taking tests, you may be given this single image and asked, what's the diagnosis? And this happens to be a tuberosinium hamartoma. And it's nothing more than heterotopic gray matter. So it's just gray matter in a place where it's not supposed to be. And the important thing is that it's non-enhancing. It can be iso-intense on T1 and T2. That's why these are difficult to pick up. They're often along the tuberosinium. And the classic teaching that we're taught in medical school is if the patient is coming in with gelastic seizures, you'll often find these large sessile lesions. Instead, if they're coming in with precocious puberty, you should expect a small pedunculated lesion, which is causing LH, RH dependent central changes causing precocious puberty. So just some details you may see in a test setting, but a beautiful case of a tuberosinium hamartoma. All right. Next case, several images, pre-contrast T1, sagittal and coronal post-contrast. And you see that the gland is enlarged, but not only is the gland enlarged, the infundibular stalk is enlarged and thickened as well. It's almost 3.5 millimeters. It should be no more than 2 millimeters at best. So something is wrong that's involving not only the gland, but also the infundibular stalk. And, you know, I shared with a nice case of pituitary apoplexy with you earlier at the beginning of the talk. And this is something very different, right? If I took away the infundibular stalk, it would look like pituitary hyperplasia. But in this case, the stalk itself is enlarged as well. 4 months later, the patient comes back and the infundibular stalk is normal and thin again, but we have lost a lot of the volume of the pituitary gland. So the pituitary gland has undergone some atrophy or some changes. So those are our clues in this case before giving you more patient presentation. And this is lymphocytic hypophysitis, where the gland and the infundibular stalk are involved. And it's believed to be autoimmune in origin and primarily occurs in women, particularly during pregnancy and the postpartum period. At the beginning, the pituitary is enlarged, very angry, very edematous, and that's because of lymphocytic infiltration. And because it enlarges and starts compressing on adjacent structures, these patients present with headaches. They may have visual impairments. Very, very rarely this can remiss spontaneously, but most often it progresses unless it's treated in time. And you'll notice that the sella, the bony sella, is not enlarged, like in our case of the macroadenoma. The posterior pituitary bright spot is preserved majority of the time, despite the enlargement of the gland. And the important thing in making this diagnosis early is that this is very, very responsive to steroid therapy. In fact, if the therapy is not started on time, the gland will be destroyed by the inflammatory process. And that's when you have that atrophic gland that I showed you in the patient who presented 4 months later. That's called partial empty sella. And this patient physiologically may have panhypopituitarism because the gland has been destroyed by this inflammatory process. So it's important to note this disease process, particularly in the patient population that I talked about, primarily women in the pregnancy and postpartum period. So if you have that kind of a patient, you see this imaging finding presentation, think of lymphocytic hypophysitis. Okay. This may be our last case. What I'm showing here is a sagittal T1 on the top left corner, coronal T2 below that, and then post-contrast on the right side. And in this case, the gland itself is actually normal. It's not enlarged, very homogeneous enhancement. but instead it's the infundibular stalk that's thickened. In fact, in this patient, it was almost 5 millimeters in thickness. And as I said before, it should be no more than 2 millimeters at best. So this is a differential diagnosis of a thickened infundibular stalk. And here's where we entertain the category of histiocytosis and granulomatous disease. You see mass-like enlargement and enhancement of the stalk. There's a whole host of things that can do this. When we think of granulomatous disease, we think of TB, which is infectious granulomatous. We can think of neurosarcoid, which is non-infectious granulomatous. But we can also think of other malignancies such as lymphoma and metastatic disease, as we have talked about before, because of this involvement of the CSF space. So it's important to remember that we cannot rely on the enhancement alone, right? The stalk is going to enhance intensely normally because it has no blood-brain barrier. Instead, it's important to note the thickness of the enhancement. As I've said before, it should be 2 millimeters or less in the transverse diameter, and it should taper gradually as it goes from top to bottom. And we didn't see that in this case, right? It didn't taper, nor was it 2 millimeters. It was very, very thick. So that's when we start considering these granulomatous and more malignant differential considerations. Okay, I think with that, we've come to an end. This is my summary slide. And I hope you appreciate the way I've presented this lecture is I've tried to give you clues which will help you diagnose these lesions, which can sometimes look very similar. So the key to the diagnosis is really the anatomic sublocation. Can you find the pituitary separate from the mass, right? If you can't, if the problem is within the pituitary, you think of hyperplasia, you think of a cystic lesion, you think of a Rathke's cleft cyst. We talked about micro versus macroadenomas. In the end, we talked about lymphocytic hypophysitis that involves the gland and the stalk. And we also talked about meningioma when we saw the mass separate from the pituitary. So the mass being within or separate from the pituitary can help you narrow your differential considerations. Patient's age is also important. We talked about germinomas being present in the first decade. We talked about craniopharyngiomas having bimodal presentations, first in the first decade, and then in the 5th through 7th decade. So it's important to keep the patient's age in mind as well when you look at these cases. The third clue is the lesion calcified? Does it have cysts? Does it enhance or not? Does it have blood products? And we saw with craniopharyngiomas, they can be very solid.
У меня там 60, вот это не хватает самых личных пациентов, да.
Микрофоны.
Mm-hmm. Yeah, and
Yeah.
it's. Is there a question? Oh, okay. So in terms of, this category, we saw that craniopharyngiomas can calcify. That's a really good clue. Rathke's cleft cysts don't enhance, but have that claw-like enhancement peripherally. We saw a case of apoplexy with T1 hyperintensity. Those were the blood products. And hemangiomas can look very similar as well. The fourth clue is the posterior pituitary bright spot there? And we saw that in germinomas, it's often absent. So that's a great case when you have the patient of the appropriate age and the posterior pituitary bright spot is not there, leading you to the diagnosis of germinoma. Finally, if you see leptomeningeal seeding, you can entertain this larger set of differentials: TB, sarcoid, lymphoma, leukemia, or there may be a primary CNS mass like a medulloblastoma that seeds with the CSF space. And finally, histiocytosis. And if you know the patient has a primary bronchogenic or breast carcinoma, then oftentimes the lesion that you're seeing in this space will be metastatic disease. So this can be a nice guide when you're looking at these kind of cases to go through this rationale, as in when you're looking at the masses, and take away clues that'll help you come down to the right diagnosis. Well, that I will end, and thank you so much for your attention and the invitation, and take any outstanding questions.
Thank you, Professor, for your brilliant lecture. It was really brilliant because you started with anatomy and you showed us the very informative cases, and you systematized these lesions located in this sellar and suprasellar region. So please, if you have any question, please write it in the chat, or you can also ask it.
Yes. And I encourage you to email me if you have questions. I'm happy to take email questions as well after the fact. Here's my email at the bottom of the slide. I would love to get in touch and connect with you all.